The other day we have seen the treatment related to the different levels of COVID, mild, moderate A, moderate B, and severe, but we didn't go into the details of the treatment of the severe and moderate disease. We have only treated the people who are at home or home isolation, or even at best the COVID care center, CCC, who are isolated and with mild disease. Now we are stepping into a next zone where we are going to have patients who are of a different degree of involvement. So the other day we discussed very much the pathogenesis of the disease. We'll just recapitulate it so that we'll be able to go better. You can see the 4 horses and the 4 horsemen, the terrorists are so-called the devils of the Christian mythology. When John speaks to in the Christian mythology, there are 4 horses. These 4 horsemen, with the horses there, they come and destroy the whole world. Just like we have the Pralaya, they also have the Pralaya there. In that mythology, that is called the Apocalypse. Apocalypse is the Pralayam. This Pralayam is by the 4 horsemen. Why they are here? What is the reason? Let us see. So we also have in our COVID Pralaya 4 horsemen. What are these 4 horsemen? The first one, the green one, is the virus replication, unchecked virus replication and virus getting out of control. And the second one is the angiotensin excess. Some more disturbance is coming. I'm still not sure who is. Okay. The second one is the angiotensin excess. And the third one is the cytokine storm, so-called cytokine excess, which we are talking. And the fourth one is the thromboinflammation. So, unchecked viral replication, angiotensin excess. Really sorry with the people. Fine. I just cannot understand. Okay. So the unchecked viral replication, angiotensin excess, cytokine storm, and the thromboinflammation are the 4 important ways in which the COVID is causing complicated COVID. It leads to DAD, diffuse alveolar damage, ALI, acute lung injury, ARDS, acute respiratory distress syndrome, and EOD, that is the end organ damage. So briefly, we will go through those things and then get into the treatment. You see here, the lung epithelium, alveolar epithelium has got 2 pneumocytes, type 1 pneumocyte here and the type 2 pneumocyte. The major cell that is affected here is the type 2 pneumocyte, which has got the ACE2 receptors, and the virus takes onto that and then produces an apoptosis of the type 2 cells. These are important for surfactant, which keep the alveoli open, and also for the generation and support of the type 1 cells. When type 2 cells are not there, alveoli cannot be open because the surfactant is lost and alveolar support for the type 1 pneumocytes is lost. That is number 1. The other important cell that is affected is the endothelial cell of the capillaries of the alveoli. So the type 2 pneumocyte and the endothelial cell, and this endothelial cell is inflamed, and then the distance between 2 successive endothelial cells is opened up so that all the inflammatory cytokines, everything comes into the alveoli and starts playing cricket in the alveolar lumen. Okay, the T lymphocyte, the monocyte, the neutrophil, the macrophage, they all produce TNF-alpha, interleukin-1, interleukin-6. These are all called the cytokine release, and that enhances the immune inflammation in the lung. So what are the cells recruited here? Mainly the T lymphocyte, monocyte, and neutrophil recruitment is occurs. So the viral replication is shown here. The virus gets attached to the ACE2 receptor there through our own protein called the TMPRSS2. This is the one which gives the key to the virus to enter inside. This protein proteolyzes the membrane there. proteolizes the spike there. Once the spike protein is proteolized, it is able to drill into the SE2 receptors and into the cell. So our own protein is helping the virus. Now, why this is important? There are drugs being developed to dampen this protein so that the virus will not be able to come and attack here. So this is down the line, and once the virus enters inside, the RNA gets into the host genome and then replicates. This is in nutshell the direct cell that is affected. Remember, type 2 pneumocyte and the endothelial cell of the capillary. Now, a little closer look. This is the once the pulmonary edema occurs and there is influx of all monocytes, neutrophils, there will be hyaline membrane formation. There will be thickening of the interstitium. A bilayered one cell here on the alveolar side, one cell on the capillary side, very easy for the oxygen and carbon dioxide exchange. Now it's converted into a thick hyaline membrane there, and hyaline formation, thickened interstitium, pulmonary edema, lots of inflammatory molecules, and lot of fluid also in the alveoli. So majority of the alveoli are not able to open because the surfactant is not there, and those which are open are flooded with the fluid. There is what is called a ventilation perfusion mismatch occurs. With the result, the oxygenation in the lung is affected. Not only that, these cytokines, they don't keep quiet, they get into the blood vessel and start producing what is called the thromboinflammation or immune thrombosis, and they trigger the intrinsic factor as well as the extrinsic factor, and that results in thromboinflammation, microthrombi. It is not something like a clot in the right atrium or the left atrium migrating elsewhere. It is the microthrombi in the circulation itself that causes the pulmonary thrombosis. So now we have understood there is inflammatory fluid secretion, inflammatory cytokines, the cells are deranged, the alveolar capillary barrier is thickened, and there is vascular integrity is damaged, and between the two endothelial cells you see gaps occur. Through that the inflammatory cells migrate into the lung, and all the active molecules that are secreted in the lung, they traverse into the vasculature and produce microthrombi. Now, so this is the type 1 pneumocyte and produces, these are all the colored molecules here are the cytokines, NFKB, reactive oxygen species, apoptosis of type 1 cell occurs, type 1 cell also dies. These are the endothelial cells, these are also infected. We know that the endothelial cell and the type 2 pneumocyte are the most important. This is the infected type 2 pneumocyte, which also undergoes the apoptosis. So this is the flooding of the cytokines here, and those cytokines causing microthrombi and thromboinflammation is the pathogenesis. Now, this part you have to understand very clearly. What happens is the angiotensin 2 is a molecule produced from the angiotensinogen 1 to angiotensinogen to angiotensin 1 to angiotensin 2, and the conversion of this angiotensin degradation occurs in the lung through a pathway called the Mars receptor pathway, and then the angiotensin 2 becomes one amino acid depleted 1,7, and this is a very protective molecule. Angiotensin 1,7 is a protective molecule. It sits on the Mars receptor and is anti-inflammatory, anti-fibrotic, and vasodilated. Whereas angiotensin 1 in small quantity it's okay. If there are excess angiotensin 2 is there, this is dangerous because it acts on the AT1 receptors in the tissues and the lung, and also in the vasculature, and produces inflammation, fibrosis, and vasoconstriction. So what happens, normally this angiotensin 2 should be degraded by the enzyme called the ACE2. But our virus is attacking this particular ACE2, and in the process of entering the cell, it is submerging the ACE2 receptor. In a way, it is drilling like with the screwdriver, it is drilling the ACE2 receptor. So many mics are open. Please don't open your mics, all of you. Again, a sincere and humble request. Okay, this angiotensin 2 should be normally degraded, and if it is not, this degradation is dependent on the ACE2 receptors, and this ACE2 is the entry point for the virus. So ACE2 population becomes weaker or lower in number, so angiotensin 2 is not destroyed. So it prevails more, no formation of 1,7. If 1,7 is not formed, all the protective effects are halted. This excess produces dangerous effects. This is what is called the angiotensin 2 excess due to the COVID virus. Okay, these receptor populations are maximum in females, and that is why the disease occurrence or the fatalities are better in case of female gender. This is the explanation that we have as on date. So let us now go and see the next slide. So see, this is a summary of all the things that I can tell you. The pathogenesis of coronavirus disease may be envisaged by the dynamic interaction of 4 vicious feedback loops. The 4 horses, the apocalypse we said, isn't it? Chained are happening at once. 4 things coming and happening at once is the disadvantage in this disease. These are the viral loop, which we have discussed. The viral loop, viral amplification occurs because the first defense is the interferon. This interferon secretion is switched off. The gene for the interferon secretion is switched off by the virus. So much so there is nobody who is interfering with the virus. So interferon is not there. Virus is just multiplying on its own without any check. The second one is hyperinflammatory loop due to cytokine storm excess, which we have already discussed, and the non-canonical angiotensin RAS axis loop, because the excess of angiotensin 2, lack of AT17 is the very important step there. And of course, the fourth one is the hypercoagulation. Severe acute respiratory syndrome, SARS coronavirus, highlights the weak by infecting the alveolar epithelial cells, which are called the AEC. This is different from the ACE. AEC is alveolar epithelial cell that particularly pneumatocyte 2, down-regulating and angiotensin converting enzyme, and that is ANG17 is altered in favor of angiotensin 2, that is excess angiotensin, less of ANG17 and the mass 1R receptor. So this results in excess angiotensin work in the lung and in the tissue. The viral feedback loop includes evading the host's immune innate response, uncontrolled viral replication, and turning on a hyperactive adaptive immune response. The inflammatory loop is composed of the exuberant inflammatory response, feeding back until exploding in an actual storm. This is what we call cytokine storm. Normally also cytokines are produced. Here they are produced in excess than the requirement. Why they are more produced? Because there is what is called the T cell regulatory gene, which is called the T cell R. These regulatory T cells are turned off. The T cell regulators will tell when to stop the cytokines, when to halt the inflammation, like a feedback check. And that feedback is absent because regulator T cells are downgraded, and that results in excess cytokines. The downregulation of ACE2, angiotensin 1,7 mass 1 axis leaves the lung without the critical defense mechanism and turns the scale to the inflammatory side of the RAS. Coagulation loop is hypercoagulable state caused by the interplay between the inflammation and coagulation. That is why it is called the thromboinflammation, immune thrombosis, immune inflammation, thromboinflammation in the endless feedback. The result is hyperinflammatory, hypercoagulable state, producing acute immune-mediated lung injury, eventually adult respiratory distress syndrome. All these will lead to alveolar capillary barrier being affected. Once the alveolar capillary barrier is affected, A6 chain suffers, ARDS sets in. Now, this is all the pathogenesis. Why all these things now? This is to know the treatment. So, you know, this slide we have seen several times, the pre-symptomatic stage, the symptomatic stage of fever, cough, myalgia, dyspnea, first 7 days, then the 7 to 14 days, the second week with respiratory failure, fever, hypotension, and all that, and ultimately the acute respiratory distress syndrome, and also the recovery phase. So antivirals are useful earlier in the disease. Suppose you want to give antiviral, we have to finish them before 14 days, not after that. Likewise, convalescent plasma, if at all is useful, it is useful in the early phases and not later. Immunomodulators like, your steroids, tocilizumab, they are useful in this region and they are not useful later on. Likewise, all adjunct therapy should continue through. This is to tell which treatment is effective in which part of the cycle of the disease. So again, this slide is a little enlargement. The viral responses dwindles from the start to the 14th day, and from the 7th day onwards, the inflammatory response starts increasing. And you can see if you have a dark brown color here, benefit demonstrated, a sort of a serrated line, benefits unclear. If at all I want to give remdesivir, I must give from 5th to the 15th day. Within that 5-day course only, we have to choose and give. The right thing is to start around 5 or 6 or 7 days. Low molecular heparin and dexamethasone from the 5th or 6th day till the end of the inflammatory. Oxygen requirement may come somewhere around the 8th or 9th day in some patients. Some patients may recover from here back to normalcy. So that is again the treatment that we have in hand are remdesivir, low molecular heparin, steroid, oxygen. And start off intubating and giving the higher treatment, and sepsis management is the critical stage. So let us go further into this disease. There is what now we are not in the DCC, and we are not in the CCC, that is the COVID care center or the isolation home or home isolation. Neither we are in the just oxygen without intubation facility, but we are in the COVID care hospital, the dedicated COVID hospital or the DCH, where all the facilities for intubation, all types of oxygenations are available. I am sure on the other day, Chakravarti doctor would have covered you the various methods of oxygenation, and we will try and see if necessary once more. Now, severe COVID pneumonia, what are the equipments that we have to treat the severe COVID pneumonia? Pulse oximeter is essential, disposable single oxygen delivering interfaces, and patient should be in the oxygen room. Immediate availability of the recognition of the cyanosis, shock, coma, or SpO2 being less than 90. Monitor the deterioration and practice cautious fluid management here. Very important, they should not get dehydrated or overhydrated. Acute co-infections with antibiotic and with bacteria is possible. Keep looking at the leukocyte count and also the procalcitonin and PCT to decide on antimicrobial therapy and give a broader cover. So this is in general the principles of severe COVID. And when you come to critical COVID, oxygen and ventilatory support, and then the high flow oxygen and the NIVs with ARD, low tidal volume, you keep prone ventilation, practice conservative fluid management, avoid disconnecting ventilator and clamping the endocardial tube if transferring onto a transport ventilator, consider airway clearance, toileting and all that. So, what are the complications that can happen to the critical person? Invasive mechanical ventilation, ventilator-associated pneumonia, VTE, venous thromboembolism, catheter-related infections, pressure ulcers, stress ulcers and GI bleeds, side effects of various drugs that we are using, particularly in a diabetic, this dexamethasone or whatever steroid you are using, it could be quite increasing the hyperglycemia to a great level. One has to be very cautious in managing the diabetes. Of course, antimicrobial resistance is a very important aspect. Now, medical management of critical COVID, there could be people who require vasopressors, norepinephrine in adults, epinephrine in children, and resuscitation stages, adult children like that. This is more a critical COVID in the ICU. I'm not going to deal too much into that. Now, most important thing is I would like you to understand how we go about with a given patient. Suppose the patient is in the moderate category. That means who is in the moderate category? A person who is more than 65 years, who is already having comorbidities, irrespective of the oxygen saturation, is in the moderate category. Otherwise, if the patient is less than 65, no comorbidities, then the symptoms are very mild, we are not admitting, but then we are going by 3 important parameters. One is the respiratory rate, the other is the oximetry, and the third one is the, of course, the tachycardia and patient's own comfort. So there is what is called the CURB score, CURB 65. This is true for any pneumonia that we admit, including the COVID pneumonia. What is CURB? CURB is C is confusion, U is urea, U is urea, R is respiratory rate, B is blood pressure, age is 65. First do a CURB score. So if the urea is more than 7, there is 1 point. Respiratory rate more than 30, 1 point. Blood pressure, SPP less than 90 or DBP less than 60, 1 point. Age more than 65. You give the score. If there is confusion and disorientation, 1 point. So how many points we can have? 1 for confusion, 1 for urea, 1, 3, 4, 5 points are possible. 0 to 1, low risk of severity. 2 to 3, moderate severity. 3 to 5, high severity, wherein the death could be 15. And the first thing that we need to do is the curb score. So how do I do that? Very simple interventions you require. And these are the measurements are, I mean, there are simple scales like not only very confusion scales are there, which you can look at, or you can even verbally ask the patient to talk to you and ask the day, the time of the day, and question several simple things, or 2 into 5, or adding numbers, and that will tell you whether they're confused or not. Blood urea measurement, respiratory rate, blood pressure, and age will tell you the curb score. Okay, I have obtained the curb score and classified my patient into 0 to 1, 2 to 3, 3 to 5. That is three grades. So if it is 0 to 1, we may not require oxygen, and he will be monitored only in the hospital. 2 to 3 and 3 to 5 are severe enough to go for the oxygen. Now, I am going to take you to several calculators now. You tell me whether you are able to see the website. Once I am clicking these things, I will be going onto the web, and probably you should be able to see the website also. And then let us see how. How is it? Is it visible or not visible?
Visible.
Visible. Sepsis-induced coagulopathy score. All these are available right on your mobile phone. You don't have to do anything. This is called the SiC6 score or sepsis. What is the question they are asking? What is the INR? Let us say INR is less than 1.2. International normalized ratio of less than 1.2 or 1.2 to 1.4 or more than 1.4. Then they are asking the platelet count. And then they are asking whether the total SOFA score, that is the SOFA score is the respiratory, cardiovascular, hepatic and renal components. And let us say in our patient, let us say the INR is more than 1.4, and let us say the platelet count is less than lakh, and then his SOFA score is let's say +1. And then whether he is confirmed positive, yes, I will say confirmed positive, and sick likely, that is in the case. What is sick? Sick is the coagulopathy, sepsis-induced coagulopathy, immune coagulopathy, or a thrombocoagulation. And that is 32%, 28-day mortality is around 32% approximately. So that is how we decide whether a particular patient is, why is important. If the patient does not have, let us say a patient has got less than 1.2, which is normal INR, and the platelet counts are less than or more than 1.5, that is 1.5 lakhs, and then SOFA score is 0, and he is only a suspected case or even a confirmed case. The SiC score is 0. Why is this important for me? Because if I know the SiC score, I will know whether I need to use the therapeutic anticoagulation or prophylactic anticoagulation. Everybody who is in this phase, moderate and severe, they must receive anticoagulation. There is no doubt about it. Can I give him the regular therapeutic dose or only the protective dose, the preventive dose? That is more important. So now I will show you another calculator like this, which will be, I am just clicking. COVID Severity Index, very commonly used internationally in most of the studies as well as in the high-end hospitals. What is this QCSI? Quick COVID-19 Severity Index. How do I get that? So some clinical parameters only we are asking here. What is the respiratory rate? Less than 20 to 22 to 28, more than 28. Pulse oximetry reading. Oxygen flow rate, whether you are giving any oxygen, is less than 2 liters. Let us say this patient with all the 3 at the lowest level is the points are 0. Risk group is 4% only. Risk of critical illness in 24 hours defined by oxygen requirement of more than 10 liters is only 4%. Let us say I go to the other extreme and I put that respiratory rate is more than 28. Already it is 2 points have come, and then the pulse oximetry I am putting at less than 88, and the oxygen flow rate is requiring more than 5 liters, and then you see 12 points has occurred. High risk case, 57% will be the requirement for high oxygen for these people. So what did I do? I did the curve score and decided which category we are. If it is minor category, no more calculations. If it is in the moderate and severe category of the curve, look at the SiC score. That is the coagulation profile. That is to decide whether we will give the minimum dose, that is the prophylactic dose, or the maintenance dose, or the treatment dose. The next one is the severity index. Why this is required? This is to know whether he should go for higher oxygen levels of treatment. That's important. Now, there is another important thing is called the Brexica COVID respiratory severity scale. This tells more about the respiratory severity. Very well widely used Brexica score, simply called the Brexica score or BCRSS score algorithm. This is a very widely worked out algorithm. I'm going to show you here what are the variables that come here. Patient wheezing or unable to speak in full sentences while at rest or with minimal effort. Yes or no? Let's say keep it as a no now. Respiratory rate more than 22. PaO2, that is the partial pressure of oxygen you measure in the arterial blood, is less than 65. SpO2 less than 90. If our ABG is not done, depending on the saturation. And chest X-ray, is it worsening or not worse? Compared to the baseline, are there any changes in this one? If everything is zero, that is called the level 0. Let us say he has got this one. We are adding 1 by 1 point. It becomes level 1. Provide oxygen supplementation for this patient. Respiratory rate more than all of you keep your microphones muted. A kind request to all of you. And then less than 65 PaO2 or less than 90 SpO2 also is there. And repeat chest X-ray, let us say, is also showing worsening. So we have put the worst scenario here, level 3. Trial of non-invasive ventilation or high flow nasal cannula recommended. If not possible, then of course you have to move him on to the intubation. Of course, the antivirals and other things, dexamethasone, are already going on. So likewise, what is happening is we are trying to trace the patient depending on the risk that he has got thromboinflammation, depending on the oxygen requirement, depending on the cytokines and all. You see, this is called Horowitz index for lung function. So can you see this Horowitz index? Can you see the Horowitz index? You are not able to see. Now you see. Are you able to see the Horowitz index? Horowitz index for lung function. Visible? Yes or no?
Visible, sir. Visible.
Okay. Now the partial pressure is in kilopascals. I want to change it into our units like millimeters of mercury. So I change it and let us write the partial pressure of oxygen in the arterial blood. Let us say 90. So partial pressure. FiO2, that is the fraction of the oxygen in the inspired air. Let us say 25% or 20% is the normal inspired air. So now FiO2 by PaO2 ratio, and then confirmed case of positive, 450 is the value. There is no ARDS. This will tell you whether somebody is developing ARDS or not. Instead, let us say the partial pressure of oxygen is 65 and he is desaturating very much, hypoxemic respiratory failure is setting in, and we are already giving him 50% oxygen in the FiO2. Inspired oxygen 50%, and then you see 130, it is already moderate ARDS, mortality is 32% chances. People will ask now, what is the prognosis? What is the, depending on, let us say he requires 100% oxygen instead of 50%. Then what will happen? He will go to 65 millimeters is the Horowitz index, that is P by F ratio, that is PaO2 by FiO2 ratio, which is severe ARDS. Mortality is roughly around 50%. Let us say if we put this as 45, even then it doesn't change. Anything below 65, the severity of the ARDS is all the same. If it is 100% your oxygen giving, then no more you can increase. And anything less than 65 oxygen, it matters very little whether it is 45 or 65 in terms of grading him, but in terms of quantifying the improvement, it will be useful. So you keep looking at the ABG every day in the ICU, and you keep monitoring. So I've shown you the 4 or 5 different ways. The first thing is the patient is a case to be admitted. Once he is admitted, just look at the curve score. After the curve score, look at the SiC6 score. That is for the coagulopathy. Then Q severity score of the COVID. And then you have got the score for the respiratory, this one, whether he requires oxygen or whether he requires nasal flow oxygen, whatever it is. Then of course, whether the ARDS scoring. So these are the various ways you titrate the patient and understand where exactly is the thing. There are what are called the Berlin criteria, very commonly used not only in COVID, in any acute respiratory distress syndrome, we use the Berlin criteria. We have discussed this during our ARDS seminar. So now what we have to do is, it has to be done within 1 week of the clinical insult. Second thing is, chest X-ray should have show bilateral opacity. Respiratory failure is not explained by the cardiac failure. If these 3 are satisfied, then only we are looking at the lung. Risk factor for the ARD is present, like COVID pneumonia. Objective assessment of echo excludes the hydrostatic pneumonia. So let us say he has got COVID pneumonia here, and based on the oxygenation, mild F5 less than 300, 100 to 200, and severity more than less than 100. So this is the ratio which we worked out in the previous slide. PaO2 by FiO2, or also called the Horowitz index. Let us say our patient's Horowitz index is severe and PaO2 by FiO2 is less than 100. That means diagnostic test result, severe ARDS, again of course confirmed suspected, unlikely, and this is only for the research purpose, and that doesn't alter the diagnosis. Let us say positive or suspected or unlikely, it is not changing, because this is true for every pneumonia. This sort of scale is required. Berlin's categorization is for every pneumonia. If you detect the COVID answer here, for the statistical purpose, it will be useful. So these are the various ways of going into the calculators and triaging the patient. Now, I am going to share the regular presentation now, so that we come back to our slides. So you people would have understood, I exhausted all these calculators, and then you have understood how to triage the patient. So there is what is called the memory aid. This is also called the ARDS classification. This is what we have seen, in that within 1 week they must have the illness like COVID, bilateral opacities, respiratory failure not explained, criteria, whatever criteria are there. This recent publication suggests modified definition of all the Berlin criteria is very useful to titrate the patient across the spectrum of the ARDS. Now, guidance for thromboprophylaxis. Remember, we are dealing here 2 issues. One, therapeutic, the other, prophylactic. Everybody who does not qualify for the therapeutic antithrombotic treatment as per that score, or who do not have any evidence of pulmonary, cardiac, vascular, venous thrombosis. These are the people who don't have any thrombotic manifestations manifest, but we are giving prophylactic treatment. How much prophylactic treatment I use? Enoxaparin is the drug of choice. This enoxaparin, I will be using enoxaparin in a dose of 0.5. That is it's available pre-filled syringes 0.3 and 0.6. 0.3 is the prophylactic dose. 0.6 is the therapeutic dose per day. Or you can enoxaparin, if you are using also, you can use. There are several low molecular heparins are available. They are in better compared to the conventional heparin. And then if you see the TDAC versus no TDAC, that is, people who are on the thrombotic prophylaxis for thromboembolism and without thromboembolism. So the in-hospital mortality rates are not much, but bleedings are also not much, but the median hospital durations are reduced, and the risk for thromboembolism development are much better. So 0.86 and 95% confidence interval is less than 1, which means it is a significant result. So we have to give the thromboembolism. This slide demonstrates that. So the red bars are those who are used where the heparin is not used, and the blue bars, deep blue bars, are the ones where heparin has been used. And this has been plotted against the 6 score less than more than 4, less than 4, and I got in the D dimer value here. The higher the D dimer, the plotting is here. You can see everywhere the blue bar is smaller than the red bar. That means the mortality is here. People without heparin are dying more compared to people who are given heparin, except in this scenario, that is a very milder disease where D dimer is less than 1 time the upper normal limit, the 6 score is less than 4, there is no point in giving the anticoagulation. That's the milder case which we are not anyway advocating anticoagulation. Anybody who is in the moderate and severe score, if the D dimer is more than one time the upper normal limit, and if the 6 score what you do has demonstrated that need for the treatment, we have to give the prophylactic heparin. And also, if there is evidence already, the thrombotic phenomena are very good, therapeutic. SiC is sepsis-induced coagulopathy. This score we have already worked out in our calculator. So, investigational COVID treatments, several investigational treatments, of course, remdesivir has to be given. When do I give? In the first 10 days or 12 days of treatment, start on as early as 5th or 6th day. First day 200 milligrams IV, followed by 100 milligrams next 4 days. Is there any benefit in extending the remdesivir for 10 days? No. The trials have shown that remdesivir 5 days is as good as remdesivir 10 days. Is remdesivir very protective, very curative? No. The trials show there is no mortality benefit, but then the severity is less, oxygen requirement is becoming less, and duration of hospitalization is less. We don't have the antiviral agent as yet, which could completely stop the virus multiplication. Having said that, we have a few antivirals like your flavipenavir for the oral use in the milder cases, and of course hydroxychloroquine also is an antiviral in the milder cases. But if the patient is severe enough or moderate enough, then hydroxychloroquine and flavipenavir are not used. Only remdesivir is used. Okay, it is an IV administration, so it requires to be in the hospital. As the other day I showed you what are the contraindications, renal, hepatic, these are the contraindications for that. And also the chloroquine, better than that, hydroxychloroquine in the first week or first 5 days, and never combine remdesivir and chloroquine, because the outcomes in the trials have shown a combination of them is hazardous compared to simple remdesivir alone. That slow slides also I have shown. Immune-based therapies, most important thing is we want this is to address the virus replication. And this here, and lopinavir and ritonavir are not used. Now the studies have proved that they are of no use. Likewise, oseltamivir. Earlier in the course of the illness, many pulmonologists and many people, they were giving oseltamivir with the hope the one which is active on the H1N1 will also act on the corona. Now we have studies to say that oseltamivir is of no use. So we don't use that. What are the antivirals I have? Flavipenavir with mild cases and remdesivir in the people who are admitted. Of course, hydroxychloroquine in the first 5 days can also be used depending on the patient when there are no contraindications. Now, immune-based treatment, now we have to treat we have treated in the previous slide, they are rather prevented the immune-based the coagulation, that is called the immune thrombosis or hypercoagulability has been treated by the low molecular weight. Now we are trying to manipulate the cytokines. What are the drugs I have in hand? I have dexamethasone or alternative glucocorticoid like solumedrol, medroxy, the methylprednisolone, whatever is the corticosteroid. Preferable drug is solumedrol or dexamethasone. Dexamethasone is widely studied in the recovery trial. We'll come to the recovery trial shortly. Now, when do I use dexamethasone? Dexamethasone should not be used in milder cases. Okay, if there is no indication to use and there is a sort of risk is more if you use in the milder cases. Only when the patient has got moderate or moderately severe or severe and critical, dexamethasone needs to be given. How much needs to be given? 6 milligrams to 8 milligrams of dexamethasone per day. That is what you give as IV, and after a week or so, once the remdesivir treatment is over, dexamethasone can be converted into oral dexamethasone. Okay, now IL-1 and IL-6 inhibitors. IL-1 inhibitors are found to be not effective. IL-6 inhibitors are found to be useful in selected group of patients. This is where we have the tocilizumab. Toci is a very potent immunosuppressor. The problem with that is if you give Toci, it suppresses the immune system totally, so much so you will not be, the patient will not be able to ward off the infections. And most importantly, we have to monitor the procalcitonin for any secondary bacterial infection, and an antibiotic cover has to be instituted. Toci has to be given only one single dose we give, and at the most, 200 milligrams single dose. At the maximum dose is 8 milligrams per kilogram body weight. Not repeated usually, unless in a very grave situation where the patient's cytokines are going up and up in spite of the first dose. A second dose of Toci may be given, but these are emergency use authorizations. Whatever I am talking, remdesivir and tocilizumab are emergency use authorizations, whereas dexamethasone is an approved authorization. Okay, anticoagulant is an approved authorization. It is not an emergency use authorization. Hydroxychloroquine, depending on the context, one can use in Indian scenario, it is being used. Okay, can I use interferon beta or early to mild COVID cases? Studies have proved it is not very useful. Can I use convalescent plasma? This is also immune modulator. We'll come to a separate slide. In one word, one liner, convalescent plasma is not effective. Okay, can I use SARS-CoV immunoglobulin, the one which is manufactured in the lab as an immunoglobulin? Certainly, yes. Very promising results are very good. If you have a SARS-CoV-2 specific immunoglobulin available, that will be the treatment probably in the future. And I think American president already has received that. And it is being tested very widely. It will be available very shortly. And then you have the BTK receptor and JK receptor inhibitors. They are tried. They are not going to be very useful in this particular. IVIG, of course, is the non-SARS-CoV IVIG is not useful. If it is IVIG of other viral diseases, it is not going to be very effective. Mesenchymal stem cell treatment is also an investigational treatment. Now, what are the passive immunizations I can give? Passive immunizations, monoclonal antibodies in the laboratory, they are produced, hyperimmune, gamma globulins derived from the plasma, the standardized product, or convalescent plasma itself. So here, the convalescent plasma study showed people who had recovered from COVID take their plasma, separate it, and use it for the antibodies. Again, there is a batch-to-batch variability. It requires matching. More than that, it also depends on the titer of the antibody in the patient, in the donor. If the donor plasma is not having a good titer, it is not going to be very useful. This is very important here. Monoclonal antibodies in the laboratory, they are very scalable, just producing Xerox copies. All the companies have the Xerox machines to copy the immunoglobulin and make it into multiple doses. Only thing is we have to evaluate and stabilize it. If suppose it disappears in 3 days after giving injection, what is the use? I can't give every 3 days or 4 days. It should be stabilized, and then it should have the half-life in the blood for at least 3 months or so. Then only that can be tried. That is where exactly the research is going on. So now, now I'm going to stop this presentation and probably go in for a couple of important things, discussion we can do, and we can see the rest of the presentation next tomorrow also. So this presentation is over. The next presentation will be tomorrow. But then I am opening here with a summary of what we have discussed. So the first important thing is COVID is not a simple disease like any other viral infection. We all know that. Why is it? It is a 4-pronged attack on the body, on the immune system, on the coagulation profile, on the angiotensin 2, and on the viral replication in the lung, all 4 hitting the body at the same time. The viral replication is hampered because of interferon switch is switched off. The AT2 receptors, AT2 molecule is increased because AEC is targeted, and AE2 is not, AT2 is not degraded, and angiotensin 1-7 mass receptor system is underplayed, and that produces the angiotensin problem. And we have on the cytokine front several immune molecules cytokines coming into the blood and producing a storm, and ultimately thromboinflammation, microcoagulation are the four important horses on which this pralaya or apocalypse is occurring. Then what do? Once the patient is admitted, then we have to triage first the curb score, second is the coagulopathy SiC score, then is the quick COVID score, then the ARDS score, then the Horowitz score, and finally you titrate whether the patient is requiring different levels of oxygen and also prognosticate his ARDS. Having done that with the calculators, then you know the interventions. What are the interventions for complicated COVID? One, I have to control the virus. I don't have the drug for the virus. The drug I have, but milder cases, fluvipenavir, not very well used in most of the people, most of the institutions. Some institutions are using it, hydroxychloroquine in the early phase, first 5 to 7 days in the milder cases. The moment he is admitted, we put him on the remdesivir 200 milligrams IV first day, followed by another 4 days, 100 milligrams IV. There is no benefit of extending remdesivir beyond 5 days. Remdesivir should not combine with hydroxychloroquine. This is about the viral front. Until we get the drug which can neutralize the virus, this is the line of treatment. Now, what do I have? Immunization. I have the corticosteroids. Should be used dexamethasone 6 to 8 milligrams from day 5 or 6 to the day 15 we use intravenous followed by the oral, and in the critical phases also it can be continued. Can I use tocilizumab? When dexamethasone alone is not sufficient, we know how to mark the immune inflammation. The other day we have to look at the D-dimer, we have to look at the ferritin, we have to look at the LDH is an important parameter. LDH tells about the lung injury, the CRP of course, and also the IL-6 are the important markers. And of course the D-dimer and fibrinogen levels also we look at. And more importantly, look at the lymphopenia. Lymphopenia is a very good indicator of severity of the disease. And having known the severity, we use the inflammatory response suppression by steroids. And second one, we can use the tocilizumab in selected cases, emergency use authorization only, single dose of 200 milligrams IV or 8 milligrams per kilogram body weight, but not to be repeated except in very exceptional cases. What are the precautions? It's a very potent suppression of the immunity. So I look for the infection, I cover the antibiotic, I look at the procalcitonin and watch for the cytokines to respond. Suppose I give tocilizumab, how many days I will expect the response? 24 hours. In 24 hours to 46 hours, 48 hours, 36 hours, you see a marked drop in the IL-6 as well as in the other inflammatory markers. So that is the way you monitor the disease. And then the second one is antiviral, second one is the anti-inflammatory, and the third, of course, you have the convalescent plasma comes under the anti-inflammatory, which we will see tomorrow. And then the third intervention I have is for the coagulopathy. Coagulopathy, we have got 2 levels. One is level 1 prophylaxis, level 2 is the treatment. 40 milligrams of low molecular heparin, enoxaparin can be given, or if the pre-filled syringe is 0.3 ml syringe, and if it is a therapeutic dose, when do I use therapeutic dose? When there is already evidence of thromboembolism, when the patient is already at higher risk of thromboembolism other than COVID, then I put them on therapeutic dose and watch for the bleeding. And then here how much I give? 0.6 pre-filled syringe or 40 milligrams BID enoxaparin can be given. Should I do PTINR? No. When you use these drugs, you need not. Suppose somebody is developing heparin-induced thrombocytopenia called the HIT, which is rather rare with LMWs. In conventional heparins, HIT is a problem. Heparin-induced immune thrombocytopenia. Whereas here, that immune thrombocytopenia risk is very low, nonetheless it can occur. Then what I do? I use dabigatran, I use epsixaban, I use rivaroxaban, the other drugs which don't have the HIT problem. And the advantage is when you discharge the patient, you can convert the patient from low molecular heparin to epsixaban or rivaroxaban or dabigatran, one of these things you can switch over to them. And how long I should continue? A big question mark. The trials say up to 30 days one can give But in general, they are stopping at the end of 21 days. Beyond 21 days, unless there is an indication to continue other indication for continuing the anticoagulation, it may not be required in a stable case. That's about the anticoagulation. So antiviral, immunosuppression, and then the anticoagulation. The fourth and the very important thing is the prana vayu, the oxygen. So that is where exactly the titrating the patient, what type of oxygen levels he requires, and the light nasal cannula, face mask, rebreather mask, non-rebreather mask, high flow ventilation, high flow, high volume ventilation, NIV different levels, IV, the invasive ventilation, where prone ventilation. All are various escalations of the oxygen therapy. The experience in the international community is if somebody goes onto the tube, less likely to come out, 40% chances only somebody is intubated. We are seeing our relatives also that then majority of the people who are on the intubation unlikely to recover. Higher forms of treatment, we have the ECMO and CyTorb, which I will discuss tomorrow. What is CyTorb? In one line, CyTorb is a machine which absorbs all the cytokines, just like plasmapheresis, just like dialysis removes urea, creatinine, and other renal end products. Here, the CyTorb is a machine which removes the cytokine excess. This is available only in a few centers. Lucky we have that in our Manipal hospital. CyTorb is there. Tomorrow we'll tell you about CyTorb and ECMO also to some extent. The oxygen treatment I am not going into detail because that has been covered by our colleague Dr. Chakraborty. So this is the summary, right from the pathogenesis to the various levels of treatment. And tomorrow we will see the different trials, the Placid trial, the CHIC trial, the recovery trial, and then the CyTorb, ECMO and all those things. Tomorrow class we will see. Okay.
Thank you, sir.
Tomorrow I am going to show you the protocol of the CMC Vellore, and also I am going to show you the protocol of the All India Institute of Medical Science, what they are doing, and like that, other senior institutions, what they are doing. That also I will be able to show you. Please, sir, ask me.
Sharma here.
Yeah.
You beautifully described wonderfully the complications and how to tackle them. Of late in America, they have been stressing more on lung transplant. What is your opinion on that? What are the cases that can be subjected?
In a very selected few patients, lung transplant will be the option, provided the cardiometabolic and other parameters of the patient are normal. Maybe briefly, I will tell you around 5 minutes on lung transplant also too. There is a question here in the chat box. What is the difference between remdesivir and flavipenavir? Flavipenavir is an oral drug. Remdesivir is an IV drug. Flavipenavir is very mild in its action, and it is useful only in the milder cases. Once the viral replication is more, it is not profound, it is not useful. Flavipenavir studies are less compared to the remdesivir. Flavipenavir is more marketed vigorously by the companies because it is an oral drug. And for example, CMC Vellore, they do not use flavipenavir. All India Institute of Medical Sciences, they are not using flavipenavir. In our hospital, they are advising only outpatient people, they are getting the flavipenavir. It is not, neither is a specific drug, neither is a wonderful antiviral like your oseltamivir for H1N1. They are only just, repurposed drugs. These are being used for other viral illnesses. This is being repurposed for this purpose. Okay.
Sir, can I comment one thing?
Please.
Dr. Mahendran.
Please,
okay. Sir, regarding this heparin, this COVID is always most of the time associated with thrombocytopenia. So why give the heparin only? Give only low molecular weight heparin, and otherwise the other thing should be your orally good dapagliflozin and other things.
Very good.
Should not.
Now, Professor Mahendran is asking, patient is having thrombocytopenia, are you justified in giving heparin? The thrombocytopenia is consumption coagulopathy. Okay, because there is a disseminated coagulation, thrombocytes are being consumed. Not thrombocyte directly. If you give the heparin, prevent the coagulation, thrombocytes will improve. That is the pathogen.
So why can't we give only low molecular weight heparin? Why should we
Low
go for the
molecular weight, all over the world, low molecular weight. But only thing is affordability. It is costlier. In a country
Okay,
like us, you can use heparin conventional, but not used many. Mostly low molecular. Mostly low molecular.
Because many people will get confused whether the thrombocytopenia at that point of time is due to consumption coagulopathy or a heparin-induced thrombocytopenia. They should be able to differentiate.
I tell
They
you,
cannot.
heparin-induced thrombocytopenia occurrence is only 2 to 3% of people who receive heparin. It is not that common. But
Okay.
what you said is, it is better to give low molecular weight heparin in order to
correct.
solve the thrombocytopenia problem. But the thrombocytopenia there
itself is due to consumption.
The effect of disseminated intravascular coagulation. So how do I improve the thrombocytes? By stopping that is the point. Another common question my patients and physicians also ask. Patient is taking antiplatelet agents, ecosprin, clopidogrel. Should I continue? If somebody is on antiplatelets, you continue. There is no need to stop.
I'll come to that.
Somebody is not on. Somebody just yesterday, the other day, one physician has prescribed ecosprin because it's mild COVID. You take ecosprin, it works. It doesn't. The point is, it is not a platelet problem producing atherosclerosis. It is the clotting factors which are being triggered by two pathways. One is the intrinsic, the other is the extrinsic. Intrinsic pathway is triggered by the cytokines. Extrinsic pathway is triggered by the endothelial damage, direct endothelitis. Direct endothelitis and tissue factor release is the cause for the extrinsic pathway. Intrinsic pathway is because of the NETosis. Nice that you brought that. What is NETosis? Neutrophil extracellular traps. NET is called the neutrophil extracellular traps. These traps are made wide open. They become more, something like a NETosis. Why that is happening? The neutrophils are deranged. They are dysregulated. There is neutropenia. With that, the NETosis occurs. The NETosis triggers intravascular coagulation. That is because of the intrinsic pathway. We know that extrinsic pathway is triggered by the tissue factor. Intrinsic pathway is triggered because of the activation of 12 to 12A and to 11 to 11A. Ultimately, the crossroad X is the center molecule. Your low molecular weight heparins, whether it is extrinsic or intrinsic, it acts on the factor X to X. So that is where exactly low molecular weights are very useful. Antiplatelet agents are not thrombolytics. Antiplatelet agents are antiplatelets. Thrombolytics are thrombolytics, and then we have also called the antithrombotics. These are antithrombotics. Thrombolytics means what you use your streptokinase, urokinase. They are the thrombolytics. That is once the large clots are there to dissolve. So there is no role for antiplatelet agents as a treatment for this. But if somebody is on, keep continuing them. Then the people are asking, sir, giving antiplatelet and also heparin, will it cause increase? Yes, it increases. That is what you are for. We have to monitor them more closely. Those who have got both antiplatelets and also the heparin, we keep monitoring them for any bleeding risk. Okay.
So one more thing is, when you give dexamethasone, after the 5th day, 6th day itself, you start off. And at the end of 1 week, because of the immunopathogenesis, dexamethasone is given. I think the recommendation should be with the antibiotics that time itself and not when the leukocytes increases, because some patients are getting increased leukocytosis after the lymphopenia because they are not covered with antibiotics and they are only on steroids and things. They are high risk of getting secondary bacterial infection, which can in fact worsen the immune process again and things like that. So I don't know whether the recommending at the start of DEXA.
What you are saying is, whenever a person is steroid, cover them with antibiotics.
Cover with antibiotics, that time it should start off, no need to wait.
Yes, but then what the institutions are doing are, usually there is a leukopenia here. Look at the increase in the leukocyte count and also look at the procalcitonin. Procalcitonin leukocyte count will tell you when you can
start and that is also.
So if you feel strongly that you need to cover, there is nothing wrong in giving. If you give a broader umbrella, not a very narrow spectrum, azithromycin or something, don't use them. That will not cover. If you decide, give a good cover. If you don't decide, then of course wait based on the leukocyte count and the
Progress.
and also the clinical picture of the fever. For example, the fever of COVID subsides after the third or fourth day. I have admitted a patient febrile, 3 days he is all right, fourth day he is getting fever. What does it mean? It is not COVID fever. It is only a secondary infection, isn't it? X-ray changes, fever, other inflammatory markers, procalcitonin. They are the guide for your antibiotic. Not empirically put everybody with dexamethasone, also write a ceftriaxone, sulfac. Not like that. Not like that.